My name is Grace Miller. I have with me Brendan Campbell, Dr. Brendan Campbell, and Dr. Alex Cavalea. We all got an opportunity to speak here in Lynchburg today. We had a great time. We've had lots of conversations I wish we had recorded. Um, and then we're going to have more conversation tonight. Before we jump off into this, I'm going to remind you guys, we're going to be in Shelton, Connecticut on June 5th. We've got Don Jenkins and John Holcomb that are going to come in and speak there. I'm going to be there. Mary's going to be there. If you're in that area, you should definitely register. It's not too late. Come see us. We're having a great time. A little bit further out, on September 19th, we're going to be in Erie, Pennsylvania. I'm going to be speaking there again. Mary will obviously be there. We're really excited. That's going to be a brand new conference for us. So yeah, come check it out. Come join us if you're in that area. So the big topic for today's conference was rural trauma. Okay, we're I think like 60 to 70% of the US operates in the rural setting. So that was a lot of what we focused on today. So we're gonna kind of continue that trend tonight. So one of the things that came up at the conference was use of pre-hospital TXA. So I wanted to kind of ask you guys what your thoughts are on that, how often you see it, if you would recommend agencies carry it, or what do you think?
Well, I'll start. Brendan Campbell, I'm a pediatric surgeon and I do some adult trauma call as well. So I kind of get to see it from both sides. I practice at a level 1 adult and pediatric trauma center in Hartford, Connecticut. And we very commonly see patients, both adult and pediatric patients, coming in and getting TXA if they have significant injuries. And we all got excited in 2011 when the crash data came out that we had improved survival with TXA. And then, fast forward a decade or more, and the New England Journal of Medicine last year published some data that said, well, patients survive, but their neurologic outcomes aren't really any better if they get TXA. So what I like to say about TXA now is that there's nothing wrong with giving it. You just don't want to prioritize giving the TXA if you're going to miss out on performing some other interventions that are going to be more impactful, like transfusing blood, if you're going to slow down the transfer and things like that. But Alex, I know, has some good insights as well.
Sure. So I'm Alex Cavalea. I'm a trauma surgeon in Knoxville, Tennessee at UT, Go Vols. I guess before we talk about TXA, I'm not sure if everybody's quite familiar with how it works and what it does. And I kind of wanted to go over that real fast, just kind of dawned on me as we were talking about it. When you're forming clot, your platelets in your blood will link up with something called fibrin, which is sort of the end of your clotting cascade, and it forms this clot. And basically, there's a normal amount of fibrinolysis that happens where the clot breaks down. It's a sort of homeostasis. It's building up and breaking down. And when you want blood to clot, you're hoping that it builds up more than it breaks down. And sometimes trauma patients will get this disordered breakdown called fibrinolysis, and you'll see just this early clot bust that happens. And so, when you give someone TPA for a stroke, you're hoping that happens, right? And for TXA, that's meant to inhibit fibrinolysis. And really where TXA became famous was like you said, the crash studies, looking at hemorrhagic shock, and it was basically, if you get it within 3 hours, you're going to inhibit fibrinolysis and improve mortality. And it's funny, things will make sense on paper and make sense from a biochemical standpoint, but then it just doesn't translate into a measurable patient outcome. And crash 3 came out, and that was all about head bleeds and TXA, and maybe if it's given within 3 hours of the injury, it'll help survival. But as far as is there neurologic outcome better? Does it actually work? These are still kind of unknowns. It's a little bit contested and debatable. And I see it given with the flight crews. Lifestar, or Erlanger has Life Force. Vanderbilt's got their own. Those are the ones that usually carry the whole blood, the TXA, and all the sexy new stuff. Our ground crews, I don't know that they're carrying whole blood yet. I don't even know that they have blood on their rigs. I'd like it to be the case, but it becomes, as we talked about at the conference, a bit of a resource thing. And but I do see it given. I'm okay with it being given. I certainly don't think it's hurting people. The question is it helping? Well, time will tell. Someone smarter than me will keep doing research on that.
So if you were, and I think if I'm understanding both correctly, which granted resources has a huge amount to do with this, but if I'm putting effort into changing a protocol to include TXA pre-hospital versus changing a protocol to carry blood, you say blood would be by and large, far and above
Yeah, I'd say
the
so.
benefit.
And we had some discussion, really good discussion at the end of the conference today, basically about kind of keeping it simple and focusing on the stuff that's the maximal benefit. And we were just talking beforehand. If you get to TXA, you're pretty far along in the algorithm of stuff you would do while you're en route to the hospital. And so, really, what this kind of crystallizes is, if you're 5 minutes from the hospital, you probably won't have time to be giving TXA. I'd rather you get an IV in the patient while you're en route, getting the patient as fast as you can to us, because access is so hard to do. Oftentimes, that's a lot of time spent in the bay for us if they're a difficult access. But if you get access, start some blood. Those are probably the two things that are going to impact the survival the most if it's hemorrhagic shock. TXA, yeah, for fibrinolysis is important, but I could start that downstream once we've got a measurable blood pressure. I wouldn't, spend time on that early on in your resuscitation.
Okay. So what would you say when we're talking about rural trauma? If I've got an ambulance crew that's going to be going, 90 minutes to the trauma center, what are some things that you guys either would expect to see from them or advice that you could give them on how do I manage a hemorrhagic shock patient? I don't have blood, I don't have TXA, but I'm kind of trying to like do that balance where I don't, bring you someone who's progressed into irreversible shock if I can help it. Like, am I prioritizing anything over something else? Hey, God, it's a fascinating question, right?
I think it's important, and I think it creates one of the big challenges that we have in providing the best care we can in rural locations. And and it sort of takes in, just to get a little bit off base for a second. There are two ways you can improve care in rural America. You can either elevate the level of care that's provided there, or you can have regionalization, which is transferring a patient somewhere else. The problem is, if you're in a rural place and you have a patient who needs blood products, what is the best thing for the patient? If you've got blood at your local hospital, even if it's a non-designated trauma center, it might be best to go there and give them a few units of blood and then transfer them. If if you've got somebody who's bled down to a hematocrit of 15, they're still bleeding, the last thing you want to do is put them in an ambulance for 90 minutes and just have them get worse. And and that's where we have to, as good and important as creating protocols and standardizing the care we have. The other thing we have to do is, you have to try and think, well, are we able to fly the patient? Is there a nearby hospital? And how far is the transport going to be? I mean, many of you all live this every day, and it can be a difficult decision. And sometimes you're going to make the correct decision. Sometimes you're going to make the wrong decision, but that's what makes our jobs hard. Your job's hard than EMS for sure.
You make the best decision you can in the moment. And there's been, I mean, where I work in Nebraska, we're about 90 minutes from a trauma center in 3 different directions. And so it's frequently, do I want to fly him from the scene? Can I get him back to the hospital? And fly him from there? Can we stabilize? But a lot of times I'm 30 minutes the other direction from the critical access hospital. So we've been presented with that a couple of times where, I can go an hour this way to the trauma center, or I can go 30 minutes that way to the critical access hospital.
Yeah.
And trying to kind of balance like how quickly are we going to decompensate? What kind of resources do we have?
I think at UT that's a pretty common reality for us. Not quite, maybe 90 minutes. So we're 3 hours from Nashville and about 3 hours from Chattanooga, and so I guess 90 minutes is probably about halfway between those catchment areas. And north of us is going to be depending on where you're at, UK, and east of us is Asheville is I think a level 2, but you get Johnson City and. So usually you're talking about 90 minutes, I guess, and so that's pretty common reality for us. I would say if you're going to go 30 minutes in the wrong direction, the thing is that they're probably not going to make it 90 minutes without any blood products, because you talk about that golden hour. There's a couple of thoughts that come to mind. One is you have to know your local system and which place has what resources. You could try to arrange a rendezvous where somebody is bringing blood to you. whether blood is flown to you or you're meeting a helicopter somewhere. And that's where, that regionalization aspect, it's unique to each place. The other thought I have is that if you have no critical access hospital, you're just 90 minutes from the trauma center and that's it.
Sure.
I want to kind of broach the subject of permissive hypotension. So I will, in the trauma bay, routinely tell the nursing staff to run a pressure between 70 and 90 before we get to the CT scanner. Now, we've got Reboa, which is a whole different can of worms, which is still not really proven to show that big of a benefit. And so some of us are kind of anti-Reboa, but my general practice is if I have someone who comes in who seems to have bleeding, but I'm not going straight to the OR. I think maybe this is maybe a low grade or mid grade spleen or a pelvic injury. Pelvic's probably the best archetype for that, where you have some pelvic bleeding. And by the way, it's probably the best application for Reboa on that subject. But I'll run their pressure between 70 and 90 because your body, that's sort of a compensatory mechanism you have. And you bleed out, your pressure's low, you're not getting enough cardiac output. And what's everyone want to do? They go, oh, that pressure's 80/40. I got to get that number up. But you're not getting hemostasis. And so you turn the pressure up. What do? They bleed that much more. And it's just like turning the pressure up on your garden hose. And you may even pop a clot. You give the patient pressors, you make their pressure 150, and then there was clot on that aortic injury, and now it just burst off of there and they're bleeding more. And so I'd say let them run a little low. Now, how low is too low? That's why I tell them don't let them stable at 70. And if all you have is crystalloid, that's what you're going to have to use. And hopefully you've got enough crystalloid. So the thing about crystalloid, we know that the data on blood and whole blood is the preferred fluid. But if you have no fluid and all you have is crystalloid, you're still going to augment cardiac output. You're not going to augment the carrying capacity of the blood and the delivery of oxygen. But you are going to at least keep their cardiac output up to perfuse those tissues. And your hemoglobin doesn't actually dilute till you get that fluid resuscitation. And so if you measure hemoglobin in a fresh bleeding patient, it's still going to be normal. And then you give them a bunch of crystalloid, and then it's going to be that 5 or 6 or 7 on the hemoglobin. And so my thought is you just run a permissive hypotension and get here as fast as you can if that's your situation. If you can't rendezvous with an aircraft or rendezvous with more resources.
Right. And I think that was, one of the things we touched on today at the conference, but perhaps may not be in the forefront of everybody's mind is like, all of our patients, especially on the medical side, like you get somebody with a pressure of like 80, we're pushing fluid, but we're also giving pressors. Like that's, they're going to die at a pressure of 80. But, you get that one trauma patient and you have to kind of remember that, in reality, they can live. It's not ideal. No, obviously 70 to 80, 90 systolic blood pressure is not great, but it's survivable for most people. And so instead of, undoing what the body has naturally created as a compensation, you kind of allow it and you end up, walking a tightrope, but, hopefully you deliver somebody that's
Well, it's a balancing
feasible.
act between organ perfusion and actually, maintaining your gas exchange. But I think what is unique about trauma is, if you have a patient in septic shock from a urinary tract infection or whatever, they need volume, and it isn't critical whether it's crystalloid or blood products. If you have a patient who has uncontrolled bleeding or has an aortic injury, the permissive hypotension may be life-saving. And I think, as long as you've got a baseline, minimum, organ perfusion from that pressure, that'll get you to the CT scanner where you can figure out what the hell's going on. And then you can either get control or, or aggressively resuscitate with blood products.
I'm sorry. Yeah.
No, you're good. So, a couple of things that I talked a little bit about today, um, as far as interventions pre-hospital that we're starting to see, and at least my interpretation would be huge assets in the rural community are things like ultrasound, especially in traumas, being able to detect that internal bleeding, because we have no other way. We can't stop the bleeding, but if we can identify where it's at, having that be an asset. But part of the challenge there being the extra education that goes along with ultrasound. Um, and so I was just kind of wondering, like, what's your thoughts on are on like how popular that's becoming, how much you would encourage somebody to kind of go through the process of educating their department and putting that in place, if you think it would be a huge benefit, or is there something else coming down the line that would potentially be
I would
better,
say
easier
if,
to
if you're
get?
a young EMT or paramedic or aspiring to be one of either, I would learn ultrasound. It is, and we talked about it today, the things as simple as placing an IV. The technology is only going to get better. AI is going to impact it, I'm sure. But you need somebody in the field to be able to do it and make the interpretation. So I think we're only going to see a greater role for ultrasound in EMS, as we've seen in emergency medicine and surgery. I mean, we don't place, you don't hardly ever place a central line now without using ultrasound guidance. And and there was none of that when I was a surgical resident, 20 years ago.
Well, and I know I went through CCP training 3-4 years ago. That wasn't a thing then. So when we went over central line placement.
When you were asking us obviously a little earlier, what do we want from EMS? What is the
Like
ideal?
ideally,
Yeah,
in a
what-
perfect world, what would you love for EMS to
Yeah,
provide
and
you?
and I don't mean this in any patronizing way, but get them to us fast. And I remember when I went through EMT school and I worked as an EMT. I was working private, and so it was a lot of dialysis and nursing home discharges and things like that. And people would be like, "Oh, you're an ambulance driver." I'm like, "No, I'm not just an ambulance driver, and I do more than that, right? I carry nitroglycerin. I never use it, but but I'm not saying just be a driver, but you're driving, getting that patient to us as quickly as you can, but also doing whatever you can on the way, gathering as much data as you can on the way. And in the ideal scenario, the patient shows up. I've gotten a phone call ahead of time telling me more or less what's going on.
Sure.
If I know it's a sick, full alert patient and they're hypotensive, I'll probably meet you in the ambulance bay or on the helipad to eyeball them. And that quick, hey, what you got? What's the obvious thing that's wrong? Kind of an informal thing, and then I'll run to the bay and actually start preparing stuff and tell the team, hey, here's what's coming in here. And you roll in, you've got an IV, maybe you've been able to give some blood already, or you have it hanging. And you don't have to have an airway. If the patient is apneic and you're bagging them, but you have an IV and you're giving blood, I'd rather that than an intubated patient that's under resuscitated. And then you give a succinct handoff telling me what your latest set of vitals are and what the obvious injuries are and what you've done. And then, get the patient moved over. And in our trauma bay, we actually have a we call it the critical pathway. We move them over right away when we say, sick or not sick, eyeball test, they're sick. We move them over and I take report from the EMTs on the side and let my team start working so that they can pass that information to us reliably. And I don't have to pay attention to my fellows guy in the resuscitation or whatever. And so that's the ideal. And so I'm not asking you to get TXA or give them Rocephin for the open fracture or give them hypertonic for the TBI. If you're doing that and you've got a 90-minute transport, and you have it on your rig or your helicopter and you're able to do it, great, you're saving me work. But the stuff that's life-saving is early access, early blood, and just keeping them from being hypoxic to the point they go to PEA from that.
Well, I know we talked a little bit at the conference today about part of the challenge of being in the rural setting is, the first thing is when you're on your way to the call, you understand your options, right? You know what the weather's going to be. You know whether or not you're going to be able to fly them. You know how far it's going to be to this hospital. If I show up as worst case scenario, I already know ahead of time what my decision is going to be, and so you're moving on scene almost faster than you would in the city because I got 90 minutes ahead of me.
Right.
What can I absolutely bare minimum that I have to do on the scene to secure the patient, stabilize, whatever, and then do the rest during transport if you're looking at something like that. And I know we also talked about, back to the basics. And I know, as paramedics especially, we get really excited when there's opportunities to do, like really cool and advanced procedures. And sometimes we forget or potentially overlook the basics.
Right.
Double checking and making sure that you have an airway, that you still, you have your pulse and your all of the things that your ABCs are taken care of.
Yeah.
And it's and I know at the conference today we talked about that happens at each level.
Right.
right? Where people kind of get that tunnel vision on this is my specialty and this is what I'm focused on. And sometimes that's when I was going through class, they said, one of the best assets about being a paramedic is if you're really good EMT, and to never take your EMTs for granted, because, and I've had this happen to me more than once, they'll save your bacon because they're the ones who are, focused on that ABC, XABC, and they can sometimes redirect you and be like, hey, before you do this big fancy thing, before you intubate this patient, how about we pre-oxygenate? How about we make sure that, we're not losing sight of the main goal.
Well, and to circle back to, you asked about ultrasound, and I kind of sidetracked us there, but the point I was trying to get back to is we've got all these advanced fancy things, kind of like you were saying. Let's stick with the basics, but that ultrasound can be a force multiplier, and any data you
Mhm.
gather, when I get report from a crew that's just they've really got it going on, and they're like, there's a femur fracture, and yeah, there was arterial bleeding coming from this arm. We put a tourniquet, and we got 2 large bore IVs. We're giving blood, and a lot of times I can get that on the helipad, the short version, and it's like they've usually caught the big stuff, and so that data gathering, it does save a lot of time and make sure we're not going to overlook something. And so if you're able to get trained in ultrasound, you've got it on your truck, and you're using it, you're proficient with it. And I think that's probably the biggest hurdle to cross. You'll probably be able to, well, hey, I ultrasound the chest and there's a pneumothorax, but he wasn't intentioned, so we left it alone. Or there's a hemothorax, but just so you know, there's a hemothorax, and then we can get our CT and see how big it is, or depending on how unstable they are, we might go a different route where we think there's an aortic injury, whatever. But I can speak to obtaining the skill. You have to get trained properly with it, and then you got to use it. And to retain the knowledge, you have to use it. Recently, my whole group, or well, maybe about half of us, we went through a critical care point of care ultrasound course to do echo, and to basically help us guide our ICU resuscitations. And it has been hard to cross the hurdle of I've got the way I've always practiced, and I'm finding the ultrasound's not affecting my decision. And it's 2 in the morning. Should I pull the ultrasound out and really bother looking at, trying to get the
Mhm.
VTI or whatever metric, the cardiac output? And there's times it matters and there's times it doesn't. You've got to check it on every normal patient so that you can get good enough to do the abnormal. And I went a little while between unit weeks, and to where I was, that skill erodes very quickly if you don't intentionally practice it. So if you go get the training and you want to, do that, everyone's got to commit to doing it as much as you can, even when you don't really need to. But obviously without sacrificing your other priorities.
Cool. Well, and I know, at least in Nebraska, ultrasound is definitely gaining traction, and I actually have ultrasound training next month. It's not something that I already know it's not something I'm gonna be naturally good at. So there's a lot of practice in my future. But I do, it'd be a huge asset, especially in trauma, especially in the rural setting, because I think, any added benefit or added tool that would kind of give us a better picture of what we're dealing with so we can make those informed decisions.
And not to go on a tangent, but frequently we talk about, I remember hearing one of the talks today, someone said, well, you've got a young, healthy patient, and they're not gonna have heart failure or something like that. Well, East Tennessee, I see a lot of folks who have a lot of chronic medical problems that get
Mhm.
injured. And you'll have a patient who we do see, they had an MI while they're driving, and that led to the traumatic
Mhm.
injuries, but surprise, there's a STEMI. We see that from time to time, and we'll also see people with heart failure, dialysis. They're on their way to dialysis and they get in a car wreck, and they're fluid overloaded. Ultrasound can actually show you there's signs. We won't get too into the weeds, but there's signs on ultrasound of fluid overload of the lungs, and would help you know what their volume status is when you're starting. So if you're worried about giving that person with that history fluid or blood,
Yeah.
I tend to err on the side of giving it, but because common things being common, they're usually bleeding to death. So they probably weren't hypotensive when they crashed their car. So
One can hope.
yeah.
All right. Um, so do you think we kind of touched on blood, we touched on ultrasound. Is there anything else you've noticed a trend that's kind of like up and coming, or that you hope gets added to the pre-hospital scope or becomes a little bit more mainstream, whether it be education or skill set?
Well, I think the one question we got today, which was really a great one from an EMT who's going to go through this training, is needle decompression versus finger thoracostomy for treating a tension pneumothorax. And and we had some good discussion back and forth, and there are pros and cons with both of them. But and it was interesting. I had a conversation with the guy who asked the question in the parking lot after. That's what's wonderful
cool.
about these meetings, a long conversation. And and he's all excited to learn it, and he totally gets it. He wants to learn it and become proficient at it.
Sure.
But it's one of those skills that requires some practice, and more than just going to a cadaver lab one time.
Yeah.
And there are opportunities. I know we've gotten away from using animals in the ATLS courses, but there are still these courses called advanced trauma operative management courses where they do anesthetized swine and they do a bunch of things, but great opportunity to practice doing those. So I think what is so wonderful about medicine, and one of the things that I remind myself I've chosen the right career, is that we're all learning continuously, and we're adopting new practices. We're learning how to do things better, and that's what makes our jobs challenging and rewarding, and these types of interactions so rewardable.
Yeah, and to
Rewarding.
piggyback off of what you said about the animal models and cadaver models, really any way you can simulate in high fidelity a low frequency, high complexity skill is going to, when the real thing hits, it's you're going to do better than you would have done had you not practiced it. So when I was a resident going to the ICU, I was a second year resident. I was nervous about my central lines. We had a pretty good simulation mannequin, just, and it was not really all that elegant. It's just a piece of rubber inside a piece of thermoplastic. You put the ultrasound, it looks like the neck does. And I went there and I stuck and I stuck and I stuck until I could get the stick and know where my needle tip was and get it the first time every time. And if you can get a high fidelity simulation, it doesn't even have to be an animal anymore. If you have access, and getting to cadavers are expensive, so that's hard. But there are some third-party companies that are coming up with. I mean, we had one demo to us with our residents to basically a trauma XLab, sort of an atom course type thing, or there's atom and acid that trauma surgeons will and trainees will go through. Only it wasn't a cadaver; it was this model where you just change the innards out and it's ready to go again. And so just getting access to a simulation center would be good. And usually individuals don't have that, but if you have a system that you work in and you say, hey, we really need a sim center.
Right.
And that's something that, at UT, we've built a sim center up for really the whole hospital. The respiratory therapists use it, the nurses use it, the residents use it. And so if you're able to get one of those simulations, I know Vanderbilt's got like a 2-story sim center.
Well, no, that's been on the education side of things,
Yeah.
kind of been the up and coming thing
Yeah.
that we've seen over the last few years. I know at Metro, we opened our simulation center, I want to say 22.
Mhm.
So I know that's been, and I've had the pleasure to visit a few of them, and they're fantastic. I mean, it's the way of the future. It's how we're going to educate and learn. But it's interesting you talked about going and practicing your central lines. I remember, I went through school. I learned how to intubate regular laryngoscope blade. A few times in the field, did just fine. They rolled out video scopes, and I missed 3 tubes in a row. Could not figure out. Couldn't get the technique down, and so I went. And even though it was just a mannequin head, I went and spent about 3 hours up there and just going through the motions and making sure my technique was right, and have not missed one since. I keep my fingers crossed. But so yeah, even if it's not, I mean, high fidelity if you can, but even just going through the motions and thinking about the steps in the process and making sure that you're squared away. I've got a whole batch of brand new paramedic students who are gonna hit their clinicals in about a month. And so we've been going over how to do IVs. And if you've ever done an IV on a plastic arm, you know that it's not super accurate. But the thing I keep stressing is learn where to put your fingers. Learn how you're doing it, because that's what's going to come in handy.
Give you that muscle memory.
Get you the muscle memory, because some of the techniques that we do, they're not natural. You got to learn how to make your fingers do what they're supposed to do. And so that's what we've been working on, and very cool. Do y'all have any questions?
Oh, there was a question, somebody
Or
had,
if
there was a
do we have any
question that was
questions?
up there, that was before. I don't know, Mary, did you see what it was? There was something I saw that caught my attention and then I got distracted.
The Roboa, it was,
Oh, someone I committed a sin. I mentioned
Oh.
Boa.
Oh, but let me, before you
Yeah.
jump to the Roboa, the one thing someone had mentioned about, just checking somebody's pulse. And that's a very good thing. One of the things that drives me crazy in 2025 is that people don't examine patients. And, and if you have a blood pressure that, a systolic blood pressure of 40 and the patient's talking to you and you can feel a radial or femoral pulse, I don't give a crap what the blood pressure measurement is, because it's not accurate. So I think, put your hands on the patient, and if they have a GCS of 15 and you're talking to you, I'm not going to intervene until we sort of figure things out. So whoever brought that point up, good for you, and thanks for reminding us of the importance of actually examining your patients and getting primary data as best you can.
Yeah. And by the way, I want to
That's a good
say, or sorry, were you finished with what you were saying?
Yeah, I'm done.
Okay. I saw Dr. Stuckey join. So, hey Lance, how are you? And hi Allison. I thought I saw Allison on there, but so one thing that someone was mentioning, Roboa. I don't know if you guys found the question, but one thing as an aside, I'm talking about in the emergency department. I don't know that I'd advocate. The military is starting to do some Roboa in the field. I think they're actually doing a trial with partial Roboa in Ukraine. So partial Roboa might change that sort of thing, but they're hard to put in. As a trauma surgeon, they're hard to put in, and I've missed them and had the access pull out, and so I would not be pushing for pre-hospital Roboa or ED thoracotomy, or even doing those at a center that's not the level 1 trauma center. Because as soon as that occlusion, you put a cross confident aorta, or you put a zone 1, or I guess a zone 1 Roboa up, where you're blocking all the vessels to the belly, you got 30 minutes to get that down. And even at 29 minutes, you might start seeing pretty bad effects from recirculation of all the inflammatory mediators from the um, uh, uh, the bowel, being ischemic. And so that's probably the reason why Roboa hasn't shown the outcomes we hoped it would, because you're blocking the blood flow off to a bunch of important organs, and when you open it back up, that all washes through. And so it's hard to get right when you're at the level 1 trauma center. So unfortunately, if you're there's an ED physician at a place an hour from us, or you're in the field and Europe, they sent a trauma surgeon to the scene. Why aren't we doing that? Those interventions unfortunately just aren't feasible in that environment.
talk about questions.
Did you have questions?
Do you want to take questions?
Yeah,
from the
yeah, we can take
audience?
questions. Yeah.
I had one more question. One
Yes.
more thing I wanted to ask.
Yeah,
And
yeah.
this was a genuine thing I wanted to ask. Because I talked about it a little bit at the conference today, and I figured, before we leave, I would actually ask pre-hospital lactate meters. And I know, like, this is something I kind of stumbled upon when I was doing the research for this talk, and so it's a completely new concept to me, but I now know that it exists, and it sounds insanely cool to me. And I googled it, and I know they're cheap. Have you heard of it? Do you know anybody that uses it? So it's a finger stick. It's almost, at least the one I found, is very much like a glucometer, like $250. But they give you a field lactate reading. I was just wondering, like, do you have thoughts on it? Have you ever seen it?
I'll
Do you have any
chime in
experience with
first
it?
as the old dog in this discussion. So I trained at a time when we didn't really pay much attention to lactate.
Okay.
But now that we have access to lactate, it actually helps you a lot, I think.
Yeah.
But the problem that I would foresee with that is getting right back to what we were talking about before. You got a patient in the back of the rig, you've got blood that you can give, you may or may not have optimized your gas exchange, and you're fiddling with this lactometer to get a lactate level, where if you have a patient in hemorrhagic shock, that you need to resuscitate them. So who gives a crap what the lactate level
You're
is?
watching the little.
That's fair.
You're watching. It's like the ABG machines. I know she's talking
Yeah.
about now, because some of I guess our flight crews have a device like that.
Yeah,
It's got
yeah.
the cartridge, and they'll show up with a whole gas.
iStat.
All the
Yeah, they'll have
gas,
iStat
Yeah,
that are-
they'll have an iStat, and they got an iStat lactate,
Mhm.
and you're watching that little thing load, waiting on it for about 2 minutes. Meanwhile,
Nobody's looking at the patient.
right, you could have been hanging that blood. Now if you've done all that and you're riding, you're looking at them going, waiting for the pressure bags up to pressure, and
What else
okay,
can I
fine,
do?
check
Yeah.
the lactate. It's funny, lactate, I've gone full circle, went from not even knowing it existed, right? Or knowing how to use it. I remember reading,
That's right.
sports surgery textbook as a medical student going, oh, lactate's the best measure of resuscitation. And then as a resident, I would chase the lactate. I'd check it every, 2 or 4 hours as I was resuscitating a patient who came back from the OR, they had an XLAP. I'd be checking it and I'd give them another bolus, the
Yeah.
lactate's down from 7 to 5, and I give them another bolus. Meanwhile, their urine output's plenty good. They're perfusing well. They're mentating. They're waking up on the ventilator.
You're fixing a problem.
So
that's not
now,
really there yet.
what I do, your lactate could be 6, and your post-op, and your pressure's good, and you're making good urine, and you're waking up, and their skin is nice and warm, and they don't really look that sick anymore. We know we stopped the bleeding in the OR. I tend to slow down because we were
Right.
over resuscitating people. We've gone from we
Kidneys
didn't
are
get
tired. Give them a
well,
minute.
and now we pump people full of fluid. We were causing ARDS and they'd swell, and so the resuscitation practices have gone back to more restrictive, and so there's too much of a good thing, right? And so the lactate I have found less useful as I've become more seasoned, because you can kind of take the whole gestalt as an experienced trauma surgeon and go, they're doing pretty good. I don't think I need to give them much more blood and crystalloid because they're off the pressors, which, by the way, I don't give pressors up front, but it's the post-op patient. They come out of the OR, they're on 15 Alevothed and they're on vasopressin. And I go, well, I tell the resident, you give them blood products till they're off that pressor, and that's how you know you're done.
Right.
And
You
and
patch,
usually they
you
get
patch the
stuff like
hole,
this.
refill the tank.
Yeah, they get a couple of units in them, and they come right off it. Usually the unhealthy ones. Now the old ones, sometimes they just need to hang out on some pressors, and everybody's got to compensate for that. They've been through a lot. So.
Do you have a couple of questions and comments? But one, Marvin Wayne has raised his hand. He's been, a physician who's been on this, Third Thursday Trauma Talk as well.
Yeah.
I'm gonna, Dr. Wayne, I'm gonna unmute you for your question, please. Or ask to unmute.
Mm-hmm.
Okay, hi, everybody. I am really the senior citizen here. Norman and I spent time, trained, worked, and a little bit of everything else together. I knew Mary when she was, I'm not going to tell you how little.
Thank you.
So, little historical background. My career started as I trained in trauma in Denver and was a trauma surgeon in Vietnam. Couple of things we did right and a couple of things we did wrong. What we did right is we gave a lot of whole blood and not all that much white stuff, because we developed something called the Nang Ong, which was ARDS. What we didn't use correctly were tourniquets. So as time has evolved, and I've evolved from surgery to 51 years in emergency medicine and EMS, just having turned over my leadership to my associate, kind of the emeritus one. A couple of things I would make a point. I live in a community that's both rural, city, and suburban. We have 300,000 people covering 2,500 square miles, and we go from the bay off the ocean to 10,400 feet. So a little bit of everything. BLS does more than it ever has. BLS does supraglottic airways after they learn how to ventilate with a bag, although we're going to be looking at other ways to ventilate than a bag in the near future. We learned that TXA could be given as a package of resuscitation until whole blood is available, and that it is both inexpensive, and giving 1 gram and actually believing the hospital was going to give the 2nd gram, no matter how quickly or slowly they do it, is pie in the sky. So we start with a military dose of 2 grams. We don't have a lot of penetrating trauma. We use a pelvic binder in suspicious patients, and we are fairly aggressive with permissive hypotension, except in those with cranial trauma. So I think all of these are doable in any system. There's nothing magic about us, except that somebody made the effort, or many people made the effort, to implement these ideas. Well, I teach at the NAMSP airway class. The biggest failure of physicians is knowing how to use a BVM or any way to simply ventilate a patient. It's really not surprising. 2, we need to teach our people that the basics are the basics, and vital signs really are vital. So with that, I'll thank you guys. It's great listening to everybody and see where things are going. And yes, ultrasound may someday be good for the field, but if you don't do it all the time, you're not very good at it. And that's part of the problem, is keeping skills.
Yeah.
You're absolutely right. Thank you.
One of the things, Norm,
You got it. You can use me or something.
I thought I was. I'm sorry. Sorry, I'm not good at this. So, Norm Rooker says that the challenge is that almost all the studies have been done in urban centers in the US. We see far less in the rural and super rural frontier medicine.
I'd have to agree with that. Like
Yeah.
there's
Studies on what?
Studies on,
probably like I'm assuming like blood products and ultrasound and like a lot of the up and coming tools that are being brought to
I
EMS.
think in general, that there are not as many.
Because
the studies are
it's a
focused
volume
on
issue.
urban,
Yeah.
and certainly not frontier medicine
Yeah.
at all.
Yeah.
Well, yeah,
Well,
it is
it's a volume issue because if I'm trying to do a study where I need 500 people, it's going to take me 18 years to pull that from a handful. I'm exaggerating, absolutely, but I'm just saying like I would assume like if I've got a new thing coming out that I'm going to focus where the volume's at. But the challenge is we have a lot of data on urban areas, and that's kind of my thing is like when you're 90 minutes 2 hours away, how can we kind of adapt current practice to work for us also?
Right. Well, sorry.
I'm sorry. So it's been an interesting thing, and the conversation, the theme of today's conference really has been rural medicine. And then we have looked at doing and want to do conferences in Montana and Wyoming, where actually you're venturing further than rural medicine. It's a frontier medicine where your call could be 4 or 5 hours away, much less of transport time. Dr. Campbell, do you have any experience with that?
I do. So I have when trauma verification visits were in person, I have participated in verification visits at every trauma center in the state of Montana. So Billings, Butte, Helena, Missoula, Bozeman. I've been to all of them, and it was fascinating to see how they adapted to their circumstances. And blood products were one of their greatest challenges because it's so far apart that and their blood supply was not as good as it is in other more densely populated areas, was a real challenge. And we've been talking a lot about whole blood and the importance of a balanced transfusion, and it's all absolutely true and it saves lives. But in a place like Montana, it probably doesn't make sense to carry blood on most of their ambulances, maybe in Billings and, perhaps in, Missoula. But,
Yes,
in a lot of
hubs.
the other places in Red Lodge and, these other tiny little places, even in Kalispell, it probably doesn't make sense. And that's where a lot of the research that's happening in the military, where they're trying to create, the blood products that don't require refrigeration, they don't expire that quickly, can potentially be used, even if they're not quite as good as whole blood.
Yeah.
So for people in Wyoming, and Montana who want to have a McSwain Trauma Education Conference in your area, we have an expert right here to talk about frontier medicine. We would love to delve into those kind of things. So contact General at McSwain Trauma Education for further. Go ahead.
Well, I wanted to add to the discussion about, a lot of the research is done in urban settings. So yes and no. I mean, like if you look at the Pamper trial, UT Knoxville was a Pamper center. Basically what Pamper was pre-hospital plasma. The flight crews would give, I believe it was 2 units of fresh frozen plasma, instead of giving crystalloid, because at the time that's what we were still doing was, the 2 liters of crystalloids before you do blood products. And you started seeing a survival benefit. Well, that includes our flights that are coming from, an hour or hour and a half away from Knoxville. So Knoxville is the only level 1 trauma center, like I said, for miles, for the 3 hours to the next trauma center. So we are, you don't have to drive far out of Knoxville to get to farmland. And so I would argue that some of the literature does involve rural populations, but even if it doesn't, just to get the numbers, to get the power for the study, you've got to control the variables you can control to see how the human body reacts. And then what the ideal is. And then applying that in the real world, well, yeah, things are a little messier in application, and when you put that into the complex system that you're working in, and maybe things aren't going to work how we want them to, and where the rubber meets the road, it just doesn't work. But I don't think it changes how the body reacts to trauma and how you treat it in the ideal scenario. So I hope that's an adequate answer. And then Dr. Stuckey had asked a question about the ultrasound before he hopped off, and how it would affect our.
Yeah. So he did
Um,
want to say that he wanted, we muted him, so he could not unmute, but he did want to, he wanted to, view for old time's sake. So.
Oh yeah. Well, in spirit of answering him, I'll just say I think that ultrasound could change my practice in the trauma bay, but we have a saying in surgery: trust but verify. So absolutely, I'd get a chest X-ray or stick an ultrasound probe. But if EMS is telling me they stuck a probe on the chest and there's a pneumo or there's a hemo, sure they could be wrong. They also could be right. So I'm going to check that early on, and because it's easier to know my ears are up. I'm expecting this thing to be a problem because usually when they tell me the leg's broken, yeah, the leg's broken. Sometimes there's just a bad laceration, it's not broken, and I take the splint off and I stress the leg and okay, it's not broken. I'd rather that than we just know nothing about it, But like we say, we want to keep it simple: get blood, get access. But if you're able to gather that data and do a full head to toe exam, and get to that step in your eval, you've got time to do that during transport. I want to know the information, but I don't fault you to not be able to get there.
So I had I see another question, which is actually really interesting. I hesitate. I feel like this could be a whole talk on its own, but telehealth in the back of an ambulance. So, and I think about there are plenty of areas in Nebraska where the 911 response is BLS, or they have to have an ALS intercept, where you have prolonged time where EMTs and paramedics, obviously rural settings, before they get to a hospital or before they can talk to a doctor. Do you have any thoughts or opinions on potentially doing something like that? Like, would setting it up where you could essentially have a telehealth visit in the back of an ambulance? Now, I have opinions and thoughts, but I want to hear yours. I'm not a doctor.
And this is fun because I haven't really thought about this before, but I think where there is potentially value, because you're gonna, if you make the wrong decision 90 minutes away, the impact of that bad decision is going to be amplified.
Sure.
If you're 9 minutes out instead of 90 minutes out, you're going to be in the trauma bay in no time. And I think there is potential for an opportunity. And I mean, what's fun for me, and probably for Alex too, we were both EMTs at one time. And I remember calling in on CMed, which was the radio in Connecticut, to the ED and giving a report. And I would love to listen to that today, because I'm sure it's probably one of the worst reports that they ever heard in the emergency department that was ever given. And it was because I was inexperienced, and I knew a 1/1,000,000th of what I know now about how to take care of injured patients. So I think there is an opportunity there, but you have to figure out how to do it well and efficiently and effectively.
I think if we were going to do that, you'd have to get, some of the swankier trauma centers, and that ain't us, but some of the like you go down I-40 to Vanderbilt, okay? They've got a big monitor in the trauma bay, and there's like a wireless thing that beams the vitals and the cardiac rhythm all up onto this monitor, and everyone in the bay can see it.
Big fancy.
In my bay, I gotta get up from behind my desk and go peer at the little monitor. That's probably the monitor. The A-line thing didn't work, and they told me that it was the only one we had left, and so that's us. So I don't have that, but you'd have to have some sort of technology where I could like basically zoom into the back of the rig, and there's a camera there, and I can kind of get a wide angle view of what's going on, and the paramedic could talk to me, and I can give him advice. I think for a long transport time, that is going to be beneficial because we can usually. And I don't want to speak for Dr. Campbell, but you can usually look at the patient wheeling in and have a pretty good idea of what's wrong. You hear the mechanism, and you take one look at the guy and go, and there's people who are bleeding in their belly, they just have a look. They're pale, they're anxious. They tell you, they look over you and they say, "I'm going to die," and they're usually right. Like the mortality prediction of, I'd be interested to do a study on the impending sense of doom. Maybe it's already been done, but like the number of patients that tell me they're going to die and then they go on and die is astounding. And it's the pattern recognition. And so You could probably tell a lot of that on camera, and just a few extra data points from the EMT, and I'm sure that would give them a lot of confidence to do some of the things you're asking them to do. Hey, yeah, you need to do a finger thoracostomy, and walk them through and how to do that, you know.
Yeah.
You ever see that commercial where the guy's on the phone with a surgeon and he's saying, all right, yeah, make an incision, and
I
shouldn't you be doing
haven't
this?
seen that, but I have heard a few times. Yeah, I've heard about it. Well, and that's it. Like I said, I can't say that I've ever actually thought about something like that being pre-hospital, but I think, you know, with the right protocols in place, because my thought is, you know, on one hand, overuse, you know, getting to the point where I don't want to do anything without, you know, doctor's permission, or kind of, and I hesitate to say use it as a crutch, but you know, I don't want that possibility. But at the same time, I can only imagine giving advice or orders for something that, you know, I'm not going to see for an hour and a half, knowing full well what can happen in an hour and a half. And I know, like, one of the things we talk a lot about in education and in the field is how, when you do contact med control, how you phrase it. Because what you can't do is go, what do I do? Because that's not, nobody gives orders over the phone. And you know, you can give options. You can say, hey doc, this is what I've got, I'm thinking this or this, and they can tell you which one. But if you say, you know, this is what I have no idea, what do you want me to do, it is not the appropriate way to phrase that if you can help it. Has that been kind of your experience, or how you?
Yeah, I mean, it.
For the most part, because I don't know, it kind of seems like we're frequently taught, don't give medical advice over the phone.
Yeah,
Like,
well,
we're taught that,
but
so I kind of assume that
So-
that extends to MDs.
Well, if there's a relationship there where you're the medical control, now I don't take those calls in our center. That's the ER docs, and so sometimes I wonder if they're saying the thing I wouldn't want them to say, like permissive hypotension. You know, they're probably not telling them that over the phone. But if I were, you know, beaming into your rig where you're 60 minutes away and you're coming, you know, from somewhere between Chattanooga and Knoxville, and I'm telling you what you know, you're telling me, hey, I've got this question, or even if you're just calling me on the phone. I mean, if that's my role, yeah, I don't give medical. I don't like to give medical advice to like family and friends over the phone, you know, or at least, I mean, we still do it, right? But that's probably the advice you were told, right? Don't give medical advice to people on the phone, or you mean
Right,
more
yeah.
work. Our role is to do that, and keep in mind too. I mean, we take the baby doctors and turn them into, you know, real surgeons, and kind of you get kind of comfortable letting someone kind of figure it out. And now, granted, usually I'm around to rescue them, but you know, if I'm walking you through something like a finger thoracostomy, I think I could do that over the phone. You know, tell them, all right, feel for the rib. You slide your finger up and down on that rib. You know, take your finger on your fingers, slide. That's how it should feel. You know, and especially if I could show them on a screen. Go right
But
over here.
the assumption
You know,
is this is
inframemory
somebody
fold,
who's
you
been
know.
taught this before, though, right?
Ideally, yeah.
Okay.
I mean, if the patient's dying, they're hypotensive, they got tension pneumo. Hey, if you're learning now, you know.
Okay, all
The
right.
thing is, the patient's going to die if you do nothing. So
That's fair.
I mean, you know, whenever we've done ED thoracotomies in the Bay, right? And one of the residents lacerated the heart on one time. Patient was already dead when you started. They were just as dead when you finished. Like, don't feel guilty over it. ED thoracotomy has a dismal survival rate. You were trying to help, you swung and you missed. I
Right.
mean, and no, I didn't know their name, and yeah, there's a little bit of that. You do separate yourself, and we can talk about PTSD some other time. But I mean, you're doing something to try to help. You had the best of intentions, and if it didn't go well, they were still going to die if you didn't do it. Now, the things that haunt us are the things that you didn't have to do it, and you did it, and there's a complication. Those are the ones that haunt you.
That's
You know, I was
right.
telling the story last night when I intubated someone's esophagus and they died. You know, and I still tell that story because that's like probably how we heal from those stories. You know, I was talking to Dr. Campbell about my 13-year-old with the hepatic veins of all soft IVC. You know, and you tell your failures as a coping mechanism, and you know, if you don't have to do something, you don't want to do it. And so it's that needle thoracostomy that goes into the subclavian when they just had absent breath sounds, but they were stable. You know, those are the ones that you want to not fall for that technological imperative to do something because you got the device. It's patients dying. If you don't do something now, they're going to die. So you even if I'm walking you through that on the phone for your first time, you know, I like
It's a
hearing the
bit
story.
different. Yeah.
Some of the guys at LSU told me. I think one of them the neurosurgeon couldn't get there. It was during Katrina, and they got walked through how to do a cranie on someone by the neurosurgeon on the phone. You know, now
There you
granted,
go.
as surgeons, we have those skills, right? It's just different
Sure.
procedure you've never done, but you know, you can walk someone through something in an emergency. To me, I'd be open to that sort of thing
That's fair.
as a staff trauma surgeon. I can't speak for everyone, but I'd be open to that. I mean, uh, I'd be waiting for my subpoena probably, but I mean, you know, the truth is, you know, when you're tried by a standard of what your peers would have done, and
Right.
you know, if you
Presented
were
with an
called
impossible
and, you know,
situation, what do you
the
do?
EMT is saying this person's, you know, they just lost their pulse and there's a tension pneumo. I hear no breath sounds. What do you want me to do? You know, is that malpractice for me to tell them to try to decompress the chest?
Yeah.
I mean, I don't think so. So,
That's
but
fair.
there's always, when you're pushing envelopes, there's always a risk that things are gonna go poorly and you're gonna get
Sure.
sued. And that's the only way we advance in medicine, though, is when you're pushing barriers.
Yeah.
So
And I think the one other thing I would just add to what Alex said, and getting back to what you had asked originally, Grace, is, you know, there is a resistance of administrators and lawyers in hospitals to give you the ability to give that sort of advice if you're not
Right.
direct medical control. But my view on that is, what's the right thing for the patient? And what's the right thing for the EMT or the paramedic on the phone? It's to give them advice and to help them, because you're trying to help the patient. And I think in most circumstances, not all, if you're trying to do the right thing for the patient, you know, you're gonna, you know, the patient, their family's gonna appreciate that more than they're likely to, you know, come after you in a lawsuit or something. But it's hard in this day and age because, you know, we have lots of regulations and rules, and it's hard to get around them sometimes.
Yeah. Very fair.
yeah, some of it's the
Well,
optics. You know, no one wants to
and-
be. They don't want to
Oh,
be the
we
one that the
hold their
trainee
child for.
practicing on, right?
Yep.
But you know, you come into our hospital, my residents do way more central lines than I do now. Now, don't get me
Yeah.
wrong, I had to put one in about a month ago, and I mean, the skill didn't go away, but like, you want that third year resident putting your line in. They're not just practicing
They're-
on you; they're the person that does the most lines in the hospital.
Yeah.
You know, and so sometimes it's the optics and the framing. You know, and when someone dies, you tell them, you know, we did everything we could to save them until the point where nothing else was going to benefit them. I always have a hard time telling people, yeah, we had to stop compressions. We were working at it for 15 minutes, whatever.
Yeah.
So,
Well, I know it's 9:04, so we've gone slightly over time. I appreciate everyone hanging out, because it's been a really exciting day. It's been a long day, but if you can't tell, we could keep talking for a while. So, were there any other last minute questions we could answer real quick, or are we calling it?
I
I didn't
didn't
see
see-
last.
I didn't see any last minute questions, but I do want to say, thank you for being here. If you want a verification of attendance, please email general@mcswaintraumaedu.com. And we will provide one for you within 5 to 7 business days. And we want to hear from you. What topics do you want to hear? There's a lot of conversation tonight about frontier medicine and austere medicine. It's interesting. We go from rural, frontier, and then austere, but it's very, but they're very good points that were brought up. If there are topics that you want to hear about, please let us know. We are here for you. We exist because you are here. Let us know what you want to hear so that we can accommodate that. And if you're interested in conferences in your area, like we are here in Lynchburg, Tennessee, or that we're doing in Connecticut, and also in Erie this year, please let us know. There will be information on our website soon, about what our conferences do and what we can bring to your area. And then so just ask us questions, general@mcswaintraumaedu.com. Thank you for being here. And thank you. I can't thank you enough, Dr. Campbell, and Dr. Cavalea. You've had long days, and Grace. You've had very long days. We've been up since 6 this morning with this
No,
conference.
we left the house at 6.
We left the house at 6, okay. And then but we appreciate the time and energy that you have donated. We are a nonprofit. All 3 of our speakers have donated their time and their energy, for being here for 2 days, and we can't thank you enough. We appreciate it. Thank you very much.
Well, but it's
Absolutely.
easy to do this when Dr. Norman McSwain is he did the same thing, and it's just a real privilege to be here contributing to his legacy.
Thank you.
So are you, right?
Solid, absolutely. So, to Daddy, thank y'all for being here.
Yeah.